So, I mean, tell me, what is the interest? I mean, Novartis and all these companies, surely they make their money from having patented medicines. So why are they interested in this issue?
Yes, I think it's a very interesting question that you ask, and we have what is called the Access to Medicines Index, the ATM Index out of the Netherlands, which ranks the top 20 companies every 2 years on how well they're doing with access initiatives. And we have a subset of the big pharma companies, the top 8 or 10, are really effectively going after access as an issue. And I've heard the CEO of one of these companies saying, we are in business to invent new medicines and sell those medicines to whoever is sick and will benefit from it. And that, I think, is what we're seeing, is that the companies are recognizing that even though the profit margins on these products may be relatively low because their ability to pay is so low, there's 3 or 4 billion people in this group of the bottom of the pyramid area that will be their future market. The growth in Europe is minimal. If we leave out the hepatitis C medicines in the last year, the actual growth in revenue for these pharmaceutical companies in Europe and North America is very slack. A country like China, 17% growth in their market as they go through very rapidly this universal health care with universal coverage. So Africa is the next frontier. We're seeing these dramatic improvements in life expectancy, in employment, in revenue generation, and abilities to pay. So I think the companies, they are benign in wanting to make their medicines available, but I think they are also looking for their strategic future. Their future growth will be in these markets, and it's starting from a low base, but there's a lot of patients with these chronic diseases, and if they can get in and have a high reputation, maybe they'll be able to persist and keep it. I'm not sure. I'm not a business executive for Novartis. I'm just evaluating it to see, do they do a good job? Does it make a difference? Does it get to the people who need them? And we'll be looking not just at the overall distribution, we'll be dividing households by income, by wealth categories, to try and see, is it the poor households who are benefiting from this, or is it the richer households that are taking advantage of these access programs?
And are you seeing a difference in the kind of NCDs that people are getting in Africa versus in Europe?
No, not really. It's very similar. The pattern of cardiovascular diseases, we see a lot more stroke, cerebrovascular disease rather than myocardial infarction. So the blocked vessels are in the brain rather than in the heart. That's one factor that we see.
What about cancer?
The cancers are different. Breast and liver are very common, but cervical cancer is very common, related to HPV, but also early initiation of sexual activity is associated with hepatitis, with cancer of the cervix. Also the lack of screening facilities. Women don't get pap smears, they don't get monitored in that way. Esophageal cancer has very discrete geographical areas where it's very common. But it varies, and it'll be a dynamic. The other thing is, how much are we missing? If we go out and look, will we find a lot more? And I'm sure we will. I'm sure we're missing cases, and particularly diabetes in type 1 diabetes, but also the maturity onset type 2 diabetes.
What about prevention? Because of course a lot of it is that people, instead of walking and cycling, they're now getting overweight, they're sitting in traffic jams. If you think of Nairobi, they're eating rich foods. Of course it's in the interest of the drug companies to sell their drugs, but what about prevention? So just getting people moving and eating better.
Now that undoubtedly is something, and we shouldn't be looking at treatment without prevention, but nor should we be looking at prevention without treatment. If we go back to the early days of the AIDS epidemic, there was a paper published in Lancet by 2 health economists from WHO who were suggesting that until all preventive activities had been undertaken, treatment should not be initiated. What we know is that treatment drives prevention, prevention drives treatment. The two have to go together. And I would argue, and there are people who would argue like you within some of the health organizations, that prevention is the only priority. Absolutely not. Prevention is a key priority, but all those millions of people with diabetes, with heart disease, they deserve to be treated, especially if it can be done for $1 a month.
So if you had one, what is it you want WHO and the ministers to do at the moment here?
What I would like the ministers to do particularly is give adequate priority to the treatment of non-communicable diseases. If I ask a Minister of Health, what about your availability of malarial medicines? They will nearly always know. If I say to them, what is the availability of diabetes medicines? Most wouldn't have a clue. It's not a priority, it's not on their radar screen, it's not something that they do. So for the Ministers of Health, we can treat chronic disease with NCDs, we should treat it, and working with different organizations, we may well be able to reach this. For WHO, I would argue that having a balanced approach, and they do, and if you read the strategy and the targets, there are these targets related to 80% availability of affordable, not just medicines, but also the diagnostic technologies. And if they can follow through on that, and all the indications are that they are, I think we will have an opportunity to move this whole process forward.
So if you would say to a minister, this is the package that it would cost per patient, what would be a package, say? I mean, is that how you're doing it?
Not at the... Well, I'm not involved in it. It's Novartis is doing it. They're aiming for this $1.50 per month per patient, because they're seeing that as, in most of the circumstances, within the ability of people to pay. So it's not dependent on the government allocating the funds. The WHO did a very good financing exercise to say, what would it cost to fulfill these targets? And it really, if you spread the cost across all of the population, we're talking $4, $5, $6 per head, but not including all the cancers. The cancers have a potential to bust the budget.
And what percent of people are we looking at? I mean, they say in Europe the risk is, 1 in 3 people getting some sort of an NCD at some point in their life. What are we looking at in Africa?
Yeah, it may well be higher than that. If we look at mortality, what do people die of? In Europe, 85 to 90% will die of an NCD. In Africa, it's still under 50. It's about 45 to 48. But in India, it's over 60%. It's going up. And in the Caribbean, we're looking over 70% of the mortality. And that may, in general, I'm not a big fan of using mortality as a measure of burden of disease. But in this case, it does give us what is the exit event and what was it relating to. So we're looking at a lot of burden of disease that is existing in these countries.
So any one last thing you'd like to say, takeaway message?
Well, the takeaway message, this morning we had a meeting with a lot of the pharmaceutical companies, some of the activists, and the takeaway message from that is many of the pharmaceutical companies are undertaking access initiatives. Very few of them have evaluated them in a robust fashion. And I would argue that this Novartis evaluation will be, I hope, a standard that all the other companies will be held to say, if you want to go to the ATM index and say we are doing access initiatives, I hope they'll be going and saying, these are the methods we're using to evaluate it. These are the indicators we're measuring to determine if we have succeeded as far as that goes. Because the companies are part of the equation, but they have to get in on the delivering the services in a robust, reliable way.
Okay.
Thank you.
And thank you. And then, sorry, just one other thing. So, have the results of this methodology come out, or the evaluation?
We will start data collection next month, and we will be publishing as we go along.
But you think that the model is what you think others should adopt?
I hope we're right. We've got it right. Okay. We made the case to them, and none of the people who were there said, no, this is wrong. Some of them were saying that will be difficult for us to do. I'm not sure I can work it through my system, and that can't you do it with a smaller sample size? And the truth is we just don't know. I hope we can. I hope we will find that we don't need to do such an elaborate evaluation so that every company, no matter how small, that has an access initiative will be able to use it.
And just one last question for you, because you obviously worked in Zimbabwe within the ministry. Is there any sort of advice or encouragement you would give actual ministries like Zimbabwe or others on this issue?
Yes, well, when I was working in the ministry, we didn't call it NCDs, we called it chronic diseases. We had registers, we had a system in place for monitoring patients. We had chronic diseases clinics, whether it was diabetes or lung disease or heart disease, and they worked quite well. So I am convinced that there are many people doing interesting work, and what we need to do is find ways to help them, rather than to say we need to reinvent. This is not a new disease. These are diseases people know about, and what we need to do is just to treat them better.
Great. Thank you so much, Dr. Laing.
No, my pleasure.
A pleasure to see you again.
It sure is. It's amazing, especially when you're looking so dazzling.
Thank you. So you. Not a moment
but 10 or 12 years ago.